have a developing science. Do you see any chance that you will be out of job soon, so that there is some miracle active which can let hair grow?
I wish. Now, this is it. How can I say? This is an excellent story. Uh, I just 27 years old when I was started the hair surgery, hormonal hair surgery. Some of my family members, or some of my friends, every time they find something in the newsletters, in the articles, and say, Dr. Richard, there is something new. And sometimes there is joke in the newsletter, and it's just like a, how can I say, advertising tricks. So one of my patients bring with advertisement tricks as a real hair growing story. So uh, I have heard it millions of times. I really wish to be retired one day, but I'm sure that it is not easy. I'm hopeful. It doesn't mean that we will perform surgery up to 100 years. I'm sure that we are going to find the genes, exact genes. We are going to treat it. It's better for them. But I don't know how much of the patients are going to be lucky for this type of medications, because we don't know the percentage of the regrowth, and we don't know the side effects now, and we have to see. We have no chance to take risk for the patients. We have to be 100% sure that they are not going to be affected badly for the hairs, because this is a cosmetic procedure. Yes, it's a surgical procedure, but their health, their cardiac problems, their psychology, their sexual activity, their skin, their livers are also so valuable for us. So we have to be sure that they are not going to be affected badly. So I'm a little bit conservative, as you know, as usual. So I'm hopeful. Let's see.
Mhm. What from today's point of view, what can the patient do beside the surgical treatment? Because we have some options like PRP, SMP, other laser, what medical treatments. What is your feeling about what you recommend the patients to do beside your surgery to maintain, improve his hair status?
Yeah, I'm also so hopeful in the regenerative medicine. Why? If you asked me these questions 20 years ago, I was really so limited by the science. We had only mesotherapies and PRPs. Maybe minoxidils and finasteride were not so active in the society 25 years ago, and we were limited. But today, we know that there are exosomes, stem cells, different type of stem cells, and not only the original stem cells, some kits, and some modulators which promote the hair growth. So we have really now increasing options for the patients. So it's also in the treatment way. I try to know and try to how can I say, use all of them, because if you don't use all of them, you have no chance to compare. You should know the mesotherapy, the logic, the mechanism. Also, you should know the stem cell. You should know the exosomes, because uh, all the mechanisms are different than each other. So if you want to compare them, you have to know them. So according to for regenerative medicine, I try to combine a lot of things, because different mechanisms may work at the same time. And I love to stimulate a lot of mechanisms. I love to play with a lot of how can I say, thoughts. So in that scenario, yes, we see really good results than before. It's clear. But this the tricky point is this: we don't know long term really deeply what I want to mean. When we stop the medication, we follow the patients 1, sometimes 2, 3 years, and After 5 years, we don't know what will happen, especially for regional medicine. When we stop, we don't know if we are going to repeat it again and again and again, because this is not limitless. You stimulate something and it works, and androgenetic alopecia is really continuing progress. And we cannot give any guarantee to the patients that, yes, this will be enough for you. I think this is the most disadvantages of the medication. But of course, for the young patients, we really have to consider it. With all medication for today's situation, uh, also surgery will not be so successful for long term. So they are going to be happy short term. They have high chance, but for long term, after 5 years, 10 years, especially 20 years, now we check our previous files, previous patients. We know that their also transplantations they are decreasing during the time. So it means that the hair surgery, especially for 25 to 35 years old patients, they need to do something else with the hair surgery. So also this is the reason that we discuss the medication with every patient now. Why? Different alternatives they can accept, they can refuse. That is their choice. I have no chance to impress them. I don't want to impress them. I only one thing from them. They have to know the options. Rest is their decision. This is my approach, but of course, different approaches are consistent in the society, and I really respect all of the approach because also some approach, yes, really maybe more aggressive, but maybe more guaranteed, maybe more conservative, maybe more safe. I don't know. We have to discuss.
In concrete, I mean, what are the patients mostly afraid of? I mean, where are the most questions you have faced from your patients about treatment? Which
With treatment, of course, they are worried about the side effects. I can say I can easily understand. Uh, because I have been working with male patients really around more than 27 years, and I know their psychology very well. And they are scared of their side effects. It is understandable, but they have to know that some side effects are not really common. So, what I can share also, I have a son, I also treat his nervous problem. I know his psychology, his expectations. I live in stigma. So it's clear that first, according to me, I want to be sure that the medication for long term will not produce serious side effects. So what I do, this is my approach. I ask spermiogram from every patient before medication. So that is the reason that I don't ask my patients, please use finasteride 6 months before to come to me. Yes, you may stay. That is your approach, I expect. But I don't want to say why. Why? There are thousands of hair loss diabetes. You may have sclerosis, you may have ATA, you may have anti alopecia areata, diffuse alopecia areata, thousands of reasons. Psoriasis, seborrheic dermatitis, needles. So, before examination, before thicoscopic examination, I have no chance to put diagnosis. Why? This you may have ACA and you may have also alopecia areata. It's not rare. We see it every day. You may have ACA, you may have LPP together. So without the examination, my approach, if I'm a doctor, I have no tools. I have to examine. So I examine the patient. I ask spermiogram first, then liver parameters, because I want to see the beginning point in a lot of ways. Why? Because maybe he has other sperm, and you gave the patients that finasteride or something else, not problem. And we don't know. Maybe he's going to blame you. Maybe you are going to be the reason. Maybe you are not. I don't know. But I want to be sure that this is the beginning point And during the time, because we generally the approach is to ask the patients to use it long term. If you want to give a medication for long term, you should follow the patients. Okay. Otherwise, you know the platforms. Everyone says that use medication, not use medication. Sometimes I'm really so, how can I say, uh, confused how you can say it so easily. You don't know the patients. You don't know if he has one renal system or if he has two renal systems. You don't know anything. You don't know the analysis. You don't know the genetic feedback. You don't know the history, family history. So how you can decide it easily? So that's the reason, please, my patients or other clinics patients, all of patients, please touch in contact your doctors. We learn every day. We change every day. I am not the same doctor as 4 years ago. I'm trying to follow the science. So we improve our information in every meeting. So please go to the clinics who has doctors. Ask your situation to your doctors. Okay? Because we also change our approach. 5 years ago's approach is different than today's approach. Okay? So if you want to get benefit, think that their surgery is the same, just like the cardiac surgery for us. Okay? Because it has same seriously for me. Okay? You can die in air surgery. You can die in air, uh, for example, in myocardial infarction after the in bypass. Okay? You have just not the same risk, but risk. Okay? So this is the reason that your name is patient, my name is doctor. This is the reason. This is the reason because we know how much risk we carry it on our shoulders before, during, and after the surgery.